which is our Q&A. So what I'm going to do now is I'm going to invite our panelists to unmute their videos so we can see everyone. And to attendees joining us here on the Zoom webinar, we also invite you to submit additional questions. We may not have time to get to everyone's questions, but you do have an option to submit questions in the Q&A box at the bottom of your screen. So as I may have mentioned, we're nearing the end of day one, but this is really the midpoint in our symposium. So when we get to the same point in tomorrow's session, what we'll be doing, Mohammed and I will be sharing our own reflections and provocations, really inspired by all 4 sessions that comprise the symposium. And that'll be a nice lead in to our Q&A time tomorrow. But for today, this time is all about you and our fabulous presenters. So we'll try to answer as many questions as possible. So what I'm going to do is I'll kick us off with the first question. And this one is a question for Katalin. And it says, what was the role of female healthcare practitioners in the provisioning of care during the 1510 plague in Hungary? So I would invite Katalin, if you have comments on this, we invite your reflections. And to our other presenters too, if there's additional observations you want to make about gender dynamics in the face of COVID or in your historical case studies, we also would welcome you after Kathleen has a chance to weigh in.
Yeah, thank you very much for the question. Unfortunately, the direct response based on my own case study is just negative, because we don't have any sources, and all those sources that we have about healthcare personnel refer to male persons. As you may have seen the list of doctors on my slide, those were all males. What we know about any female participation comes from not so much the plague hospitals or leprosaria, but normal almshouses in cities. There we have inventories and we have female personnel, caretakers, cooks, wards, and so forth. But it was not very typical to have any educated healthcare personnel. So unfortunately, the gender aspect is not very strongly represented, and not so much on the basis of my own case study, but I'm sure that many of the examples from later hospitals, what we saw from the other speakers from the 18th, 19th century, may be more instructive for this question.
Does anyone else have any observations that they want to make about gender in their own case studies?
I was just going to mention that Lady Mary Montagu highlights the fact that women were in charge of inoculation in the Ottoman Empire. So that's an important point.
Thank you.
Not related to the cholera epidemic I've been talking about, but later in 19th century London, excuse me, Florence Nightingale was astonishing, and I've been looking at her. We named our British Field Hospital in London Nightingale Hospital for her. She had spent time in Turkey, in Scutari, where she worked for the British Army. She returned with several lessons from there. She then established a nursing hospital in St Thomas's Hospital in London. She established a nursing school, and she published notes on nursing in which she categorically stated what a healthy building should look like and how nurses should conduct themselves. She was influential in the design of St Thomas's replacement hospital that was built across the Thames from the Palace of Westminster, and she was hugely influential, very politicised. So I'm full of admiration for her, but you know, she was a bit of a special case in some respects.
In the case of Bombay, we know that the treatment of women during the plague epidemic and in regards to plague control measures was a very prominent topic. it was kind of one of the base reasons for riots that broke out in 1897 in response to epidemic control measures. The fact that women were being examined at transportation hubs and in hospitals by male doctors. And we know that the British government or the colonial governments to some extent acquiesced to these demands and started employing female practitioners to examine female patients, especially in train stations when people were being examined for symptoms of plague. So there's definitely, gender is an aspect of kind of how people suffered, and also an aspect of how control was handled, and the kind of misstep in considering gender or not considering gender was a very important and long-term effect.
Okay, we have a question by Fezanor, who is actually asking Daniel whether the hospitals over there in Portugal were, how did they function in the city? How did they take the patients to the hospital? Were there any, these kinds of jobs were being subcontracted? And that has to do with this kind of infrastructure that we rarely discuss in our study of the public health in the early modern world.
Yeah, that's a really good question. I haven't found any records on how patients were taken to the hospital. We have a lot of information on the admission room and sort of the admission process. So that's assuming that one would walk there and be admitted, be able to walk there. We have a little bit more on in case they died. So in case they died, then the hospital staff would be responsible for carrying them out of the infirmaries and out of the hospital too, and preparing the body and all that.
Thank you. And there is a question for Fariba, Professor Zarinabaf. When were cemeteries transferred outside Istanbul's city walls?
Well, some of them were, and this was usually in Galata and Pera and in the 19th century. A lot of cemeteries were inside the walls, but in the 19th century, as the city also gets overbuilt, after the fires, they built over the cemeteries and then they get transferred. So it happened in the 19th century.
Thank you. We have another question here that's asking specifically about the role of the horse as a means of transportation in creating unhealthy conditions. So I'm wondering if anyone has any thoughts on that particular mode of transportation, but I think this question enables us to think more broadly about the role of movement. Some of you have already spoken to this idea, so I'm going to first see if anyone has any thoughts about the horse in particular, and then open it up to observations about movement, different forms of movement, different modes of movement, and of course, the relationship to epidemics and their control or lack thereof. Anne-Marie?
So in London, when Bazalgette is designing and laying down the sewers, they have to embank the River Thames, and they spend a fortune on it. And that enables them not only to lay sewers underneath the embankment, but also to advance the underground. And of course, London is a huge city in the 19th century and has massive problems with overground transport, in particular, heaps of horse dung. So in a very tangential way, this facilitates the reduction, at least, of some of the detritus from the horses, because the mass transport system that takes place in the embankment or the underground alleviates it somewhat.
Yeah, go ahead.
I was going to. I can talk about mules. I'm not quite sure that's not quite a horse, but it's almost a horse. No, mule trains, of course, were how products were transported in Castile. There are many accounts of mule trains being stopped at the walls and basically camping outside the walls and being very closely inspected, not only because of whatever it was they were carrying, cloth usually, or foodstuff or whatever, but also the mules themselves. And there was concern that animals of all sorts, but particularly mules, could transport bubonic plague. Which I have to say, for a long time was poo-pooed by historians, because as we all know, it's just rats and fleas. Well, it turns out no, it's rather more complicated than rats and fleas, and that indeed mules and every other sort of animal may have at some point been a host for bubonic plague. So mules were an issue. Horses, to my knowledge, were not.
Thank you so much, Ruth. We have a question for Mehreen. Do we have any evidence for European physicians' influence at Jahangir's court or any other kind of cross-cultural exchanges, especially between Europe and Mughal India when it comes to especially pandemics or epidemics? And this is kind of interesting because I raised the same question in the practice session.
Thank you for that question. Referring specifically to Jahangir's reign, we don't have any kind of documentation of physicians, as in like the proper sense of the word, there and being active. We know of lots of other Europeans who came to the court, who were active at the court. There was a particular English adventurer, Thomas Coryat, I believe, who is in Jahangir's empire from about I'm not going to get the dates quite right, but somewhere between 1615, 1620. And he does kind of masquerade as a physician and doles out advice and kind of gets, paid for these, for his advice on how to treat the sick. During Shah Jahan's reign, so Jahangir's son and successor, we do have a French physician, Bernier, who is traveling throughout the empire, who is at the court, who is writing and making, suggestions and helping with medical questions and the like. So we do have people present with a medical background from Europe at various points in time at the Mughal court.
Thank you so much. Let me ask another question that's kind of a more general question, which I appreciate because it allows us to sort of amplify some greatest moments from our presentation so far. This is a question that's asking for some more ideas or maybe kind of a refresh on kind of outcomes of these epidemics at architectural and typological levels that are somehow different than these urban hygienic interventions and large hospitals. So what are some standout ideas that maybe one or two of our panelists want to amplify from their own case studies or other examples they've come across?
There's actually a case, this lets me talk about my absolute favorite part of my research, which is that part of the research that ends up happening once the rat flea theory is verified to some extent and accepted in India is a bunch of research about kind of building out the rat that happens, where there are these experiments that are done where scientists are kind of like putting rats in these big like metal sheet containers and seeing how high they can jump and how far they can climb, and trying to build these kinds of a lot kind of barriers or blocks and to stop rats from getting into houses, or giving suggestions to kind of raise the foundation of homes up so that rats are less likely to kind of get in at the ground level. None of this really comes to pass. As with most epidemics, there's kind of like a rush of ideas, and then the execution is actually the difficult part. What does end up happening in Bombay, though, is that the plague epidemic leads to this kind of provides one of many kind of incentives for this improvement movement that leads to the kind of raising down of a lot of housing, opening up of streets along kind of miasmatic and hygienic, at the kind of intersection of germ theory and miasma theory, these kind of like opening up of spaces for ventilation, which actually displaces a lot of people. And so that's one of the things that I've kind of wondered is whether this is going to change the city and who's going to get displaced if we need to create more space between people.
Great point. Thank you. Sophia, did I see your hand earlier? Is there something you want to add in here?
No, I've been typing my responses to in the chat. I hope that's okay.
Great. Danielle, I saw that you wanted to contribute too.
Yeah, I can think of instances, especially in Venice, of temporary structures being built outside of the city to house immigrants because they were concerned about outbreaks, especially people coming from the East, refugees. They were concerned about them coming from areas where they were having some kind of outbreak. So either repurposing of existing warehouses and things like that, or building actual shelters to isolate them in a certain area of the city.
Thank you. And Fariba, I see your hand.
Yes, so I mentioned this, but I wanted to also highlight that, Istanbul has been a pandemic hub for a long time, since the ancient times with the first pandemic. So the policies really changed the city in terms of, the movement of populations outside the city walls, in terms of also the reconstruction of buildings. And I want to also highlight that the fires were also a big factor. So the state took a holistic approach, a response both to fires and to epidemics. And some of the factors were the same, like overcrowding, the use of wood in construction. So in the 19th century, actually the city, especially Pera, becomes very European because you have also European architects who are building because they have to live there. So they bring their architects, and you see that, Pera becomes more and more similar to European cities, especially Marseille, because most of the merchants are from Marseille. They're investing in the city. The middle classes are investing. So there's also the commercialization of urban space. So whenever a building is destroyed or a neighborhood, and we have big fires in the 19th century, that's the moment when you can see the investment of the rich people, of the wealthy people, pushing out the poor and taking over the property and building commercial infrastructures, which, leads one to kind of, wonder whether some of the fires, like the big one in 1870, were deliberate. So my response would be that, the Ottoman government takes a very holistic approach, but at the same time, the interests of European communities and commercial classes also take priority.
Thank you, Fariba. So we do have a question from Zainab, who is asking, do we know anything about the social protests of women against urban regulations during quarantines in your case studies? Did you find anything that has to do with this? Ruth, you want to talk?
Protests in general against quarantine? Is that the question?
Yes.
That's interesting because I just wrote a very little piece about this. No, I mean, comparing to today, I mean, when I see the protests today in the United States and in Spain, which are the countries I most know, they're invoking some sort of patriotic, nationalistic, sort of value-laden reason why this quarantine is an affront to our supposed liberty. And so you're weighing our freedom against these allegedly irrational and totalitarian restrictions. At least that's a lot of the discourse in the United States and Spain. In my experience in 16th century, I found nothing like that. They don't like the quarantine, of course. They protest, they write letters, they petition, they scream and yell, and they say, we need the markets, we need the commerce, but nothing along these, it's a whole different discourse. That is, the prior one is economic need and public health. The one today is highly political.
Right. Any other responses by the panelists?
Just to kind of reiterate that this is a huge point in British India in plague control, the kind of the experience of women who are kind of suffering from plague and also suffering from the kind of disparate or like culturally insensitive plague control measures leads to riots and protests. So
thank you.
Thank you. Our next question is from Merle Eisenberg, and it's asking about this sort of focus on the macro and the micro and the interplay of the two. Emily, I know this is something that you talked about in your presentation, but I'm also recalling here at Kathleen, really thinking about local government, then kind of larger scale governmentality. Fariba, I think you had this kind of nice dynamic too of different locations, and Anne-Marie. So I wanted to just kind of pose a not very well-formed question, unlike the question that was posed here by Merle, to really think about what can we learn, or what do these examples tell us about the interplay between the local and maybe national or even global forces, in particular thinking about epidemics, their outbreak, and their intervention.
I can. So I think, you know, the Ottoman case is really fascinating because it's really kind of between, I would say, the Mughal and, you know, the rest of Europe. And in the case of the Ottoman Empire, one answer that we came up with, you know, discussing this issue with my students, I'm teaching a grad seminar on the Mediterranean, is that, you know, the Ottoman Empire avoided, you know, this all-out quarantine system, partly because, you know, Istanbul is the center of trade, both domestic and international. So for very similar reasons, you know, as today, you know, some people are resisting the quarantine, the Ottoman state actually resorted to sort of selective interventionism. So i.e., if, you know, you can have quarantines in Venice, in Dubrovnik, in Split, in Marseille, that's going to, you know, sort of control a bit, you know, the spread of the plague to a place like Istanbul. So in the 18th century, you have these debates. And of course, you know, the lack of quarantine in the Ottoman Empire prior to the 19th century has been blamed on conservative religious figures. But again, you know, in the 18th century, the empire is becoming very, very secular and very westernized. And the Ottoman state does not always follow the lead of religious figures. I mean, you know, in that sense, it's a very, very different Islamic state. And it's also a Mediterranean state, i.e. it has a large Greek population, it has a large European population, so we can't really refer to it as a typical Muslim state. So one has to kind of really see how it's negotiating between these different cultures and traditions of public health. And finally, in the 19th century, they open up. You know, so when the situation demands it, they become global. And then it's really through this global collaboration that they're able to eradicate the plague in the 19th century as much as they can. And I think that's going to be the talk tomorrow. Reza Noor is going to talk about that. So it is really, you know, their negotiation between their commercial interests, right, the local and the global, and the fact that they see themselves as part of the Mediterranean world. So they resort to the same policies, but, you know, selectively.
Other thoughts here, Anne-Marie? Yes?
As I started with my talk, you know, I sort of said that England, until the reforms of the 1830s, England is administered by the sort of honeycomb of many, many tiny authorities, and any kind of public health or welfare is administered on the unit of the parish, which is microscopically small. And if you think about, for instance, a river, I showed you the cartoon of the River Thames that was a satire on the polluted river, and if you looked at it carefully, you could see that you had this man, he's called John Edwards Vaughan, who owned the Southwark Water Company, and he's sitting on an outlet buoy. So that indicates that sewage was flowing into the river from the north bank of the River Thames in the county of Middlesex, but being taken in on the other side of the river in a different administrative district in Surrey. And so even though in England there is quite good epidemiological progress being made, actually doing something is stymied by the fact that you need to have some bigger scale authorities that have agency, who can take a bigger view than simply the really, really local. And yet, as we know now, and Britain is just going into a new phase where we're doing notionally a track and trace. The local, in terms of the minute control of the epidemic, is essential, but in terms of the infrastructural, I think, you know, that you do need to have a bigger picture.
If I may also add something to this question of the interplay between the global and the local, I was really fascinated by many of the other presentations. For instance, the example of Lisbon, where a huge royal hospital was erected. And it was just, would have been unthinkable in any states of Central Europe at the end of the 15th or early 16th century to think in those terms. There was so much left to the urban communities, the municipalities. All treatment of any kind of epidemics was left so much on the local level that it really contrasts very starkly with these measures of the huge Mediterranean cities. And what is also striking that the rulers, the kings, gave trading privileges to every single important city along this route which I showed you. So there was an awareness of somehow this route hanging together and being something important in general for the kingdom. But all the consequences which were caused by the movement of goods, of people, and the movement of diseases were relegated to be treated on the local level. And in the same year when this case study, by example, this pamphlet was published, there was also epidemic all over the country, and the king did nothing else than moving the diet from the capital to a location further away. But and then he fled even further west, so he could afford to take this kind of precaution. But there was absolutely no concerted effort being made at this time. So the contrast is really quite stark.
Thank you, Katalin. So we do have a question by Matthew, I think, who is asking us about the blaming foreigners and minorities during times of pandemics. And that's unfortunately what we are experiencing these days. So I would like to remind that we are going to have a whole session on urban life, and a big portion of that is going to be dedicated to racism and kind of the blaming minorities. So I think we will have a longer discussion about this tomorrow.
So I have another question, which is thinking about social disparities. Many of the cases that we've seen today, and indeed many that we'll see tomorrow, are really amplifying this idea that epidemics do not hit different cities or populations equally. And so this question is from Nalini Singh, and it's asking us to be forward-looking. So how might we think about, how might we kind of look forward? How do we control and intervene in epidemics to be a bit more socially minded, and to, in particular, really support communities that don't have access or the same kind of access to different resources? So any thoughts on sort of maybe lessons learned or big ideas for how maybe we might envision a more humane future? Emily?
Yeah, I think that the one thing that I've learned, or one of the bigger things that I've learned from looking at multiple epidemics in multiple spaces for my project, has been that the investment has to come before the epidemic hits. That really it's a commentary on existing social stratification and the lack of attention that often goes on for decades before an epidemic arrives. And so it comes down to questions of preventative and proactive health care and urban structural care that are very hard. And I think one of the biggest challenges is that it's kind of hard to see the forest for the trees when there's not a kind of imminent epidemic threat. But then that's when it becomes very clear that we don't have the proper infrastructure to deal with it.
So we do have a few questions about the availability of the presentations. I want to remind our attendees that we will be posting all these sessions on our YouTube page, as well as responses by major public health figures. So please just expect another email from us, so you will hear about that. however, honestly, we never expected this, long list of great questions by our attendees. So my suggestion is that we will kind of filter some of them, we will categorize them, and we will share them with all speakers at the end of our conference, our symposium tomorrow. And some of you are already asking us about the publication. Yes, we are not going to be publishing proceedings for this conference. However, we will turn this material and we will publish an expanded volume based on some of these case studies and other case studies. So hopefully in 1 year, we will have a publication on this topic that will overlap with what we have done here.
Do we have time for one more question, or is this our official goodbye?
It's up to you. And I know that several people are asking questions about the parallels between the contemporary crisis versus these historic ones. And honestly, I think this is such a major question that we don't want to just waste this question. So I think I would suggest that we keep this question for the end of the symposium, if Caitlin, you are fine with this, so that we have a more kind of expanded discussion on this tomorrow.
That sounds good. So let us just say thank you so much for all the fabulous questions. Again, we are excited that this is really the start of a conversation, not only just in this symposium, but also everything that comes next. So many thanks. It's wonderful to be part of this truly global community that came together to present all these sessions today, as well as to ask these great questions and just to be present. So huge thanks to our fabulous presenters. Please, everyone, join us again tomorrow, same time, same place, same Zoom link. And thank you, everyone, once again.
Yeah, I want to thank everyone again for these wonderful presentations and wonderful questions. Again, if you asked a question that was not addressed here, we will definitely address them tomorrow. So don't feel that we ignored these questions. Thanks so much, and it was a pleasure having all of you in this symposium, and we'll see you tomorrow.
Thank you.
Thank you. Goodbye.